1972, the United States Congress passed Public Law 92-603, signed by President Richard Nixon. This law created the Federal End-Stage Renal Disease Program, extending Medicare benefits to eligible people of all ages diagnosed with ESKD to cover the high cost of medical care.
There was passed this law that essentially created a benefit that afforded them access to a life-saving therapy independent of their age, independent of their condition. Prior to that, there was tremendous opportunity for inequality in who got access to that therapy.
It was that 1972 legislation that really relieved the burden of caregivers having to decide literally who would live or die based on their condition.
To understand what happened in 1972, you certainly have to think about where we were as a country and as a healthcare system in the 60s and early 70s. Dialysis was a relatively new and novel treatment. It was incredibly expensive, and so you had a lot of patients who were suffering from end-stage kidney disease, from kidney failure, who had a stark choice, which was try and figure out a way to have dialysis funded for them, or unfortunately, not receive any treatment and die.
In the early days of dialysis and before the Act, it was very unusual to see patients over the age of 50 being dialyzed.
The legislators opted to rely on private industry to develop a network of dialysis centers across the United States.
At the time of the 1972 Act, there were a little less than 5,000 patients on dialysis. About 40% of those were being treated at home.
After the law, you began to build this infrastructure up that ideally supported the in-center hemodialysis population. That's what grew for many, many years. Government said, we don't want the government to provide this. We want the private space to provide it. So people need to step up and make the investments that need to be made to do that.
These private, many of them for-profit organizations, did a wonderful job in terms of what Congress, in a sense, intended, which was make dialysis and kidney care, hopefully including transplantation, widely available.
Prior to the legislation passing, experts thought that the dialysis program would be small, since most people with ESRD would be too sick to even consider dialysis. They estimated that only 1 in 5 people diagnosed with ESRD would be considered dialysis candidates.
Some federal government employees built some kind of a model in which they were aiming at, well, what is steady state? That means when the number of patients passing and the number of new patients is equal. And so at what point would that be? Their prediction, steady state, would be 25,000 patients. That's how big the ESRD program would grow.
Today, dialysis is sometimes a treatment option even for people with complex medical conditions. In 2020, the number of people in the U.S. living with ESRD was just under 808,000 people, and the total Medicare expenditures for beneficiaries with ESRD was $50.8 billion.
If you look worldwide, there are millions of patients receiving dialysis. To contemplate that number of lives that would have been extinguished without the availability of this therapy and the industry that it created, I think is really quite astounding.
We have lots of gaps that we need to fill and improve upon, but we actually have matured this kind of care probably more quickly than it otherwise might have occurred.
You started to see an explosion both in the number of people who were going to be on dialysis as well as the cost of care. And so in the decades that followed, and really this ramped up in the late 90s and early 2000s, you started to see Congress and the folks at the Department of Health and Human Services and CMS take a really hard look to say, this is untenable. The cost of care is simply too high.
47 years after the legislation was passed, President Donald Trump signed a 2019 executive order focused on reimagining the delivery of dialysis and kidney care.
I think the incentives in the reimbursement system are now better aligned with choice of therapy. And I think there's also more emphasis on getting patients started correctly when they need dialysis and to get the necessary preventive care.
You had the federal government paying for on the order of 90% of patients who were on dialysis. And so you had a single payer really focused on what can we do for this patient population? How do we involve physicians, nephrologists, primary care physicians, endocrinologists to take a more holistic view of this? And so as a result, you started to see Health and Human Services and CMS start to get a little creative.
Kidney failure is not just a U.S. or a developed world problem. It's a worldwide problem.
In response to the U.S. legislation in 1972, many other nations with mature healthcare systems also took up the discussion about providing dialysis to their citizens living with kidney disease.
And even for those that couldn't quite afford it, to begin to ask the question, what could we do to create some level of access to care? And I think that's been why this movement has grown. And Fresenius Medical Care was right at the heart of those discussions with many healthcare systems and building up the infrastructure to provide that care.
The transformation of kidney care in the U.S. is giving the power of choice to patients, with a focus on returning to home-based care and organ transplantation.
People ask all the time, integrated care, value-based care, this makes perfect sense. Why wasn't this done 10, 15 years ago? Because there was never the payment model to recognize that it's okay to pay something physicians today in the hopes of saving money tomorrow. If you pay a capitated rate, if you pay a percent of premium, if you come up with these value-based models to pay providers dollars today, that gives them the wherewithal and the resources to do some really creative things.
There's no doubt that the future of healthcare is in value-based care. And the secret of success in value-based care is making sure that the goals and incentives are aligned correctly, that the best outcomes are being rewarded, and that appropriate care, timely care is being rewarded. And so that the reimbursement flows to quality and not necessarily quantity.